Hi, good afternoon. That's me. I'm coping with Parkinson's. And I've recently retired, and I'm willing and able to do whatever needed. I was diagnosed with Parkinson's in 2018, but in retrospect, I think that I started to experience symptoms about a decade earlier to the diagnosis. Some of you are familiar with this part of the presentation, so feel free to take a nap. I think that my journey with Parkinson's began in 2006 when I was diagnosed with a cerebrospinal fluid leak. I underwent a mastectomy to resolve the problem, but unfortunately it did not work, and I continued to lose my hearing as a result. In 2015, I experienced a severe case of meningitis and ended up in the ICU. Following this episode, I underwent a further testing to find the hole or tear in the dura that caused the CSF leak. This resulted in undergoing another surgical procedure, a temporal craniotomy meant to seal the leakage. I'm happy to advise you that this went successfully. In about 2010, I started to experience the occurrence of drop foot in my right foot, meaning that I had no control over my right foot, and I started walking without control of it. However, it did not affect my motor functions at that time. In the first years or so, it did not really bother me, as it did not affect, nor did it impair my daily life. However, the phenomenon worsened over the years and took an additional form, such as cramps of the foot and severe spasms and clawing of the toes, in an arched position that was very painful and difficult to loosen. Neurological exams for gross muscle strength were completely normal. In the following years, I had seen almost every neurologist in the country, and no one was able to assist me. Everyone was looking at the drop foot as a syndrome and nothing else. It got to a point that I was not able to walk 100 meters without experiencing severe back pain and stumbling very often. This was really affecting my mobility, which was rather depressing, as I started to realize that I was losing my independence. At this point, I was very determined to get my mobility back and continued to seek answers. Finally, in 2018, I met a rehabilitation orthopedic surgeon who, after a very long session, said, "Well, this is out of my expertise, but I think that you need to see an expert in movement disorders." I immediately understood the meaning. I have Parkinson's. It took me 10 more days to get to the Parkinson's clinic, and the first thing the neurologist said to me after giving the diagnosis was, "You must be very active, 2.5 hours weekly of aerobic exercises and 2.5 hours weekly of anaerobic training. This is the minimum." I'm trying. After the first shock of being diagnosed with Parkinson's, I have started to think, what next? Since then, in 2018, the Parkinson is taking its course, and I can see its progression. However, I am trying my best. Physical exercise, being active as much as possible, traveling and hiking, having good days as well as bad days, mobility-wise. But well, here I am, and it's 2024. It took me some time to realize that physical activity is very crucial for my mobility. I learned the hard way that if I do not exercise regularly, my gait worsens. Mobility is essential for my independence, the ability to walk alone, stand up, sit down without needing help. Mobility is essential to my well-being. Mobility plays a crucial part in the way I cope with PD. The fear of losing independence due to impairment of movement. I am not alone in this experience of mobility, as Tom and John, my colleagues in the patient advisory group, highlight. They talk about why walking is important to them, providing examples of the impact that and the changes to walking has on them, and how they both feel that it isn't considered enough by physicians.
Why is walking important to you? Because you have COPD. And I say, because it keeps me mobile, it keeps me going.
It's very important that I can actually walk. As I say, it's the only means of transport I have is my two legs. And if they pack up, that's it, I'm afraid.
Once I missed a connection at an airport on the way to a COPD conference because I just couldn't walk from point A to point B. And that's when I recognized that I needed help. And the next time I flew, I had wheelchair assistance. And the first time I sat in the wheelchair, I just started weeping. To me, it was horrible. I have an elderly woman able to walk, pushing me down the concourse to get from one gate to another because I couldn't do it myself. Emotionally, very disturbing.
Not to be able to walk in a straight line. And the minute you start sidestepping, people automatically think you're drunk, which can be very embarrassing. I had to go to the hospital to visit my mother. So I had to get two buses. So I had to get from one bus to the other bus. And the other bus, there was a queue. And I also find it hard to stand still. And I moved a couple of steps. And the fella behind me says, "I think you've had one too many, sir." And after that says, "I haven't been drinking. I've got Parkinson." So it's frustrating in a way because you automatically been found guilty before you've been tried.
Neither my primary care provider or my pulmonologist asks me when I do see them how much I walk each day and how active I am, and am I able to navigate stairs, get to the mailbox, go to the grocery store. It's simply not brought up.
I used to go to a neurologist every 6 months, and he's in there. "How are you doing?" I said, "I'm okay." Yeah. I say, "I'll walk a bit staggery." "Okay, yeah, we'll just keep your medication." "Okay, there you go. Go and see the girls." That's it. I'll see me longer waiting in the waiting room than actually being with the doctor. But as long as you can get from A to B, no matter what it takes, I feel as if they're not really interested.
I'm proud to be part of a significant research project that aims to benefit the future of people with movement disorders. I'm very happy to be involved in the project throughout the patient advisory group and through other groups. I feel that our voice as patients is being heard and that we make a difference. Being part of the patient advisory board was a very meaningful experience for me. I know others in the group have felt the same. Some of them have provided some quotes about their experience as part of this research project, and which you can see here on the slide. I think that in this specific project and in every research, pharmacological and none, a patient's view or voice has a great impact on the project throughout. Hearing the patient's voice benefits the project. The patient is the research field from which the researchers draw the data. Now that Mobilise-D is coming to an end, I feel strongly that there are issues or aspects that we did not address yet. I would like to see the next steps addressing these additional aspects. As we know, some of the non-pharmacological treatments are dancing, occupational therapy, and speech therapy. Of course, exercising as well. Patients with PD or other moving disorders are not referred automatically to a speech, occupational, or physical therapist. If you know of one country or health program that does it, please let me know and I will be there. So for the next steps, I think it's important to measure and compare movements for target groups of individuals who take part in these activities or treatments and those who do not, to measure effectiveness. The effects of these treatments can perhaps be measured using tools created in Mobilise, so it is important that we begin to use them in trials. As you can see, what other group members hope for in the future. Thank you for the great work you are doing in researching this field, but mostly thank you for hearing the patient's voice.